Excellent. And then, wrapping this conversation or this section, I should say, with a discussion on semaglutide, which I think is going to be an important medication for cardiologists to know because of the patient populations that we serve and treat. I think is certainly an important therapeutic armamentarium for, risk factor modification in our patients. Do you want to talk about semaglutide?
Yeah, this is another medication that represents an expansion of our understanding and knowledge beyond cardiology.
When saving lives is what you do, your standards are anything but standard. In fact, you set them higher than most to deliver results that patients can depend on. You refuse to compromise. We couldn't agree more. We are Edwards Life Sciences, and like you, we believe that good is never good enough. Rising to the challenge of today's TAVR patients isn't just a mission, it's a commitment. And because you set a higher standard, we set our sights on meeting you there. Welcome to the higher standard, your standard. Learn more at edwardstavr.com.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Happy New Year. It's 2022. Welcome to another episode of Parallax. This is season 4 of Parallax, and we begin where we left off in 2021, having Dr. Nijjer on the show again as part 2 of the wrap-up of what happened in 2021. I apologize if my voice is a little twang. I'm recovering from COVID-19, and wherever you are listening, I wish you safety and health. And if you haven't gotten vaccinated or boosted yet, my recommendation is to please do the same. I'm not trying to downplay Omicron, but the good news is that it is not as severe as the ancestral variant or the beta variant or even the Delta variant. So, stay safe, get vaccinated. And with that, Sukh, welcome, and thank you for doing this for us again.
Oh, it's a pleasure to join you again, Ankur. Thank you very much for the kind invitation. It's great to be joining you to discuss some of these studies from 2021. I'm sorry to hear about the COVID. It's incredibly rife. It's really ripping through the United Kingdom, and the case rate is absolutely phenomenal. And it does, it does look, unfortunately, that the vaccinations are less effective for Omicron. But what we have seen is that there is a huge reduction in hospitalization, and the severity of the illness is much lower compared to the other variants. Younger people seem to be getting it, and that's not to say that unvaccinated people are going to be completely fine, because we still have full intensive care units. But as I'd echo your message for everyone to get vaccinated if they can, because it does definitely reduce the severity of the illness.
Absolutely. So with that, we're going to jump into cardiology and, where we left off in 2021 and start discussing about heart failure. And I know that there was, a lot of data presented on Sglt2 inhibitors and non-steroidal mineralocorticoid receptor antagonists. So I can't wait to get started and learn more from you.
Yeah, let's dive in. So the SGLT2s really are proving to be the true blockbuster drugs, probably of this decade, really, right up there with the advanced developments in the PCSK9 inhibitors. But these appear to have added value in a cohort of patients that really haven't had very good treatments. And the audience will be familiar with SGLT2s over the last 3 years, have had great outcomes in reducing cardiovascular events and in diabetic patients, and this was shown in a group of pivotal studies which were meant to demonstrate safety, but seemed to show improved outcomes when you add SGLT2s to diabetic patients. And then there was the DAPA-HF study, which showed overwhelming benefit in patients with reduced ejection fraction, so those with cardiac impairment. If you add in dapagliflozin 10 milligrams to standard of care, there was a huge reduction in outcomes. And I happened to be in the audience at ESC when this was presented, and there was an audible gasp in the room, with massive room, and you could hear it wherever you were. And the data was very compelling. And then it's worth saying that this has now been replicated in a number of different studies as well. So this does look like this is likely to be a class effect. And on top of DAPA-HF, there's now the Emperor-Reduced study, which has demonstrated that empagliflozin, which is another SGLT2, has a similar reduction in hard endpoints. And this is where we can start to debate a little bit on the nature of the endpoints used in these studies. But in Emperor Reduced, there was a similar reduction, around a 25% hazard reduction in cardiovascular death and heart failure hospitalization in patients with reduced ejection fraction. And it was highly significant with a p-value of less than 0.0001, so very significant. And overall, if you look at the data from Emperor Reduced, you see a pattern that's very, very similar to that of DAPA-HF. Some marginal differences, slight differences in the level of mortality reduction that was seen in this particular study. And there are lots of reasons for that. And perhaps the sample size was a bit smaller, and perhaps the follow-up was a little bit shorter, which may have driven that. And there was perhaps a higher rate of drug discontinuation in the study. So that can all account for that. But then also this year has come out the SOLOIST study, which is a slightly different SGLT2 drug. It's a drug that it's unfortunately an orphan drug now because the manufacturer has seemingly run out of money or funds to be able to do it. But I think the outcome of SOLOIST is so good that one of the other companies may take the drug on. And this particular medication has a combination of both SGLT2 and 1 inhibition. So the listeners will know that SGLT2 is a co-transporter in the kidneys. And by inhibiting it, essentially the patient will pass more sugar in their urine, and therefore there is a reduction in total blood sugar levels, so HbA1c improves, there's a loss of calories, and so there tends to be a weight reduction and blood pressure seems to come down. And there seems to be some additional components. We don't quite understand how it's achieving such an improvement in heart failure. There may be a change in the heart muscle using ketones. There appears to be some atrial receptors, parts of the atrial muscle appear to use SGLT2 enzymes, and so there may well therefore be an additional benefit there. But in the sotagliflozin study, this drug also binds SGLT1, if I can say that, and that's in the gut, and therefore you absorb less sugar, and therefore there's an alternative additional an action. And in that study, there was also, just like it's been seen with DAPA-HF and in Emperor Reduced, we see a significant reduction in cardiovascular death and heart failure hospitalization. So heart failure hospitalization is a little bit of a softer endpoint, but of course it's an important clinical endpoint to patients because heart failure patients often spend long periods in hospital requiring IV diuresis. And the costs of hospitalization are highly significant, both here in the United Kingdom, and the average inpatient stay can be 21 days, which is very long. And that's a huge, particularly for older patients, where their quality of life is already significantly reduced. Being in hospital for that length of time is really quite profound. So I don't discount that as the valuable outcome measure. And then to top it all off, so not only do we have this highly valuable set of drugs working in those with heart failure with reduced ejection fraction, this year we've now seen probably the big blockbuster study of the year is the Emperor Preserved study. And it's shown that these drugs are useful in those patients with so-called preserved ejection fraction. And again, we can debate over this because the study isn't really classical preserved ejection fraction. It's predominantly patients with an ejection fraction of more than 40%. And they took those patients, around 3,000 patients in each arm. And these are all patients who are very well treated, in fact, very high levels of both ACE inhibitors and ARB use and beta blocker use. So it kind of implies that this is a mixed cohort of patients where the cardiologists looking after these patients are giving them medications that ostensibly don't have a classical indication in preserved ejection fraction. And what they found by adding empagliflozin on the standard of care was there was a significant reduction in the combined endpoint of both cardiovascular death or heart failure hospitalization with a 21% relative risk reduction. and a number needed to treat of 31. So that's really quite impressive in a cohort of patients that traditionally have not had medications that have been proven outcome. You'll know that last year the Entresto study looking at heart failure with preserved ejection fraction was narrowly negative, and therefore the drug doesn't get a license extension for it in that particular cohort, certainly not here in the UK. But these empagliflozin represents the first SGLT2 inhibitor that has been proven to have benefit in this cohort of patients. And the benefit was seen in both patients with and without diabetes, and all the different subgroups had similar benefits. So it is quite a historic outcome, and it is important. And I think this study was rightly applauded when it was first announced earlier this year. And it came out at ESC this year in 2021. And it came out at a time where actually it was too late for it to go into the guidelines, because, of course, Teresa McDonough and her colleagues who rewrote those guidelines have to set a stop date for them. So it's not currently in guidelines, but I can imagine that it will be added in soon. And we have to wait for the DELIVER study. DELIVER will look at the use of dapagliflozin in a very similar cohort of patients. So those patients with ejection fraction of more than 40%. And we'll begin to hopefully get to see, again, a class effect. And then we can start to work out when we start giving these medications to patients who often have a heart failure syndrome, so breathless, they're fatigued, often have ankle edema. But when you perform an echocardiogram, their ejection fraction can typically be around about 50 to 55%. So some people may argue that this is mid-range, and there are lots of different terminologies now for heart failure. But certainly we've now got medications that have a huge benefit over and above the traditional use of ACE and beta blockers in this cohort. So what are your thoughts on this study and these medications?
Yeah, so, excellent summary. Thanks for summarizing so eloquently the studies on SGLT2 inhibitors for us, Sukh. I agree with you. I think these drugs are going to be, the next statins, if they aren't already, particularly in the kinds of patients that we see in clinics. I'm a strong proponent of quadruple backbone therapy for patients with heart failure with reduced ejection fraction, which include a beta blocker, an SGLT2 inhibitor, and ARNI, which is the combination of sacubitril and valsartan, and Invalidocorticoid receptor antagonist. I think that backbone, the sooner you start patients on that backbone, I think the sooner they are recipients of the benefit with, several percentages of absolute risk reduction and mortality, certainly heart failure hospitalization as well. So, I've certainly gotten very comfortable in prescribing SGLT2 inhibitors in my clinical practice. One of the side effects, which, I'm not sure you've come across, but I certainly have come across, at least in a couple of patients, is dehydration. And I think in part that is because of the glucosuria that you were describing early on as a mechanism of action. Have you encountered that in clinical practice with prescription of SGLT2 inhibitors? And if you have, then, what is your strategy in terms of co-prescription with diuretics?
Yeah, you're absolutely right. So we have seen it, and when we first started using these medications, we worked very closely with our renal physicians. At my particular institution in West London, we have a massive renal unit, and our nephrologists are incredibly keen on these medications because the canagliflozin study, the Canvas group of studies have shown that these medications preserve renal function over time. And so these are proving to be very useful in these complex metabolic patients, often with renal dysfunction, often with diabetes. They often have stiff ventricles. We usually give them quite a lot of diuretics. And you're absolutely right that when we start giving them, they can get quite a big diuresis. Now, the amount of diuresis they get is directly proportional to their blood sugar levels. So if they're diabetic, they tend to get quite big diuresis. And then as the blood sugar levels begin to normalize, they get less. And so that dehydration should become less of an issue. But what we found is that we can usually cut back on the diuretic. I've got a few patients where I've ended up keeping the diuretic the same because it didn't quite achieve what I thought it was going to achieve. But in the majority of patients, I've now seen that we can usually cut back on the furosemide or Lasix, as you'd call it, or bumetanide. And one thing that you have to be a little careful of is that you expect to see a slight change in their EGFR. The calculated EGFR is likely to fall a little after initiation, and then what we see is a little bit of a rebound and then normalization. And that's normal, and that can lead to people becoming very concerned, and it can lead to people stopping the medication. And certainly here in the United Kingdom, I understand that there's going to be a license extension, so we can give these medications right down to super low EGFRs, which I think is very useful because, it's been shown time and time again that they have a renal protective effect. And the other thing that's unusual about them is even though they work predominantly through the kidney, even those patients with renal impairment, typically on very high doses of Lasix, still infer a benefit, even though their kidney function is reduced, and therefore you'd think, maybe this medication won't work. It's not that the kidney function is a contraindication. It's just that we think that the medication is less likely to be effective if kidney function is low. So I do think they're very useful. I think it's very important for cardiologists to become familiar with the use of these drugs. Certainly discussing with patients about why you want to use them. I think it's always worth telling patients that hygiene needs to be very important because urinary tract infections, fungal infections in the genital areas are very common. And I've certainly had to become very familiar with how to deal with that in our cohort of patients. So I think that's important advice. And primary care physicians, certainly here in the United Kingdom, are very experienced in dealing with that. And so working in conjunction with them, usually we can keep patients who are suffering, the consequences of very sweet urine, which means urinary tract infections or candida infections. Usually we can keep the patient on the drug. And it's been rare for us to have to discontinue it, either due to dehydration or infection.
So what is, do you have a favorite among Sglt2 inhibitors? I know there's a class effect between dapagliflozin and canagliflozin and empagliflozin. I typically try to prescribe dapagliflozin simply because it's an easier dose and frequency combination to remember for me. But do you have a particular choice amongst your prescription patterns?
So we started off prescribing empagliflozin most because the original set of studies that showed profound effect in a post-MI cohort of patients were with empagliflozin. And then what we found was the DECLARE set of studies that unfortunately perhaps show a more modest benefit compared to empagliflozin, showed that in the kind of more standard kind of patients that you may see, and particularly in primary care or those patients without major cardiac events, without significant MIs, we're probably better off just having dapagliflozin. And so we've then ended up going down the dapagliflozin route more commonly, and then DAPA-HF really sealed the deal with that. So we're probably now prescribing dapagliflozin in the majority of patients. And as you say, it's with all of these drugs, whilst there are different doses, I think in the cardiac use, it tends to be a flat dosing structure. So we tend to just prescribe the single dose, and we tend not to escalate it, certainly for cardiac indications. So we're happy to use either empagliflozin or dapagliflozin at a flat dose.
Excellent. So let me ask you something. In terms of patients who get diagnosed with de novo acute decompensated heart failure, are you comfortable prescribing these medications in hospital, or is that something you do as an outpatient? Because I think that's an important distinction for some of our colleagues who think it may not be wise to start the prescription in hospital, whereas you now have accruing data showing that the sooner you prescribe them, even when these patients are in the hospital, diuresed, transferred to a telemetry bed and getting ready for discharge, the sooner you put them on the quadruple backbone, the better it is for patients in terms of adherence and follow-up.
Yeah, absolutely. So that's a very good question, because remember that the license and indications is for stable heart failure as opposed to acutely decompensated. However, there are dedicated studies. The names and the acronyms of the study escapes me, unfortunately, but there is actually a study that was also presented at AHA just recently that has shown that it is safe to start in patients who've had acute decompensation, usually once you've got them off IV diuretics and usually at the time of discharge. And so it is safe, and that is what we do. in a similar way, there was a time when, we weren't starting the ARNIs de novo. We were going through the process of initiating an ACE, escalating all the way up, and then making the switch, which is laborious. And then it was eventually proven that the ARNI can be started de novo, and even in acutely decompensated patients. So as you become more familiar with these drugs, I think people will become relaxed about when they initiate them. And technically, that is a creep. That is an indication creep beyond where the licensing of the drugs were. But this is the simple reality. And just like, it's been well shown with when beta blockers first became indicated, there may be listeners who are old enough to remember there was a time when beta blockers were contraindicated in heart failure. Rather than being an absolute indication, it was the absolute opposite. And there are still physicians out there who will stop beta blockers when patients come in with decompensated heart failure, or stop it if there is an intercurrent event in the fear that it will cause heart decompensation. But actually, it's been shown that if you do that discontinuation, then the patient's much less likely to have the drug reinstituted. And then the patient is exposed to poor outcomes. And as has been shown in lots of studies now, if you stop these medications, particularly in the cardiomyopathies, you find you get a destabilization, you get a reduction in ejection fraction. And actually, we do the patient harm. So it's usually better just to keep the drug on. So the earlier you get it on, as you say, and the longer you keep it on, the better it is for the patient. And we have to counsel the patient about that, and we have to tell them sick day rules so they understand there are certain times that we drop the drug, just like, we should, if you get diarrhea, you should probably stop the ACE inhibitor as well, because you'll get dehydrated and we don't want an impact on the kidneys then. And that's also an indication for holding off the SGLT2. But as long as we tell and counsel the patient that, I think these drugs can be used very safely.
Excellent. So moving on, do you want to tell us and educate us about the non-steroidal invalidocorticoid receptor antagonist that's on the horizon for patients with heart failure?
Yeah, so this was new to me, and I read with interest about this as looking through the various studies of the year, and there was a study called the Figaro Dkd Study, and it was essentially a study looking at a unique drug. It's a non-steroidal mineralocorticoid antagonist. It's called finerenone. So it's a bit like spironolactone or a eplerenone, but it seems to have this added value that it reduces the progression of diabetic kidney disease. And it does so by about 20%. So it's like the SGLT2s that have a benefit in patients with kidney disease, and it reduces the likelihood of developing renal failure. These medications seem to do something very similar. And this particular study, the Figaro Dkd study, was looking at patients who've got renal impairment, the kind of moderate renal impairment that are typically of patients with heart failure that we tend to see in our clinics. So not patients who are on dialysis, but patients with reduced GFR. And what they found was there was a reduction in clinical events with 30% reduction in heart failure admission by the addition of these drugs. And we also saw improvement in renal outcomes with basically a sustained reduction in eGFR loss. So that's important, and renal death. And these is basically a very important outcome, because big reductions in eGFR means that patients end up on dialysis, and renal death, as we all know, is usually a very terrible outcome, and having severe end-stage renal disease is a very frightening situation for many of our patients. But the reduction in heart failure events is important, particularly in this particular study, because these patients were all very well treated. They were all patients with ACE inhibitors and on ARBs, very high percentages. And what is interesting in this particular study was classical overt heart failure with reduced ejection fraction was excluded in this study, but a lot of the patients had preserved ejection fraction. So that means that these renal patients with preserved ejection fraction, if we can add a medication like finerenone, we see a reduction in outcomes in clinical events, we see a reduction in heart failure events, and we see a preservation of kidney function. And so you begin to see that this is a class of medication that our renal colleagues, the nephrologists, will be very, very keen to use. And it seems to be a whole new class of treatments that hitherto we weren't really aware of. So I think that this will be a group of medications that we'll end up using probably together with drugs like the SGLT2s. We don't know, there won't be head-to-head studies, I imagine, for quite some time, but I imagine that they will be used in a complementary fashion. So I thought this was a new class of medications that was worth mentioning, and I'm sure we'll hear more of it over the next few years.
Excellent. And then, wrapping this conversation, or this section, I should say, with a discussion on semaglutide, which I think is going to be an important medication for cardiologists to know because of the patient populations that we serve and treat. I think it's certainly an important therapeutic armamentarium for, risk factor modification in our patients. Do you want to talk about semaglutide?
Yeah, this is another medication that represents an expansion of our understanding and knowledge beyond cardiology, and it really it's quite good for cardiologists to become general physicians again sometimes, and semaglutide represents this. And the reason I wanted to mention this and discuss this with you, Ankur, is because we work very closely with some of our endocrinology colleagues, and within our trust we have a very large bariatric service who support patients who are overweight and help them lose weight, typically by performing operative procedures. And then in the last year, there was this really compelling study called the STEP1 study that looked at a GLP-1 agonist, semaglutide, which is an injectable. And patients have to inject it usually once a week. And what they were doing were looking at non-diabetic patients who were all obese with BMI of more than 30. And basically looking to see what weight loss was achieved in over a period of time. And what was remarkable in this study, it was a randomized control study, well performed, with an international cohort of patients, was they had really quite profound weight loss. And what we were seeing was around 15 kilos of weight loss, and which was sustained over a long period of time, usually occurring after 3 or 4 months use, and the study continued typically for around 68 weeks in total. And so a 15 kilo weight loss is really quite profound. And what we saw overall on average was around a 15% reduction from baseline in their weight, which was then sustained. So I think this is really quite profound, because I'm sure in your service you have patients who are big, and that will contribute to a lot of their overall morbidity. So big patients tend to have obstructive sleep apnea, and sleep apnea drives AF, and it drives hypertension, and it contributes to hyperlipidemia, and the hyperlipidemia leads to coronary disease. And so if we could just help patients lose weight, we find that we can probably improve a lot of their cardiovascular outcomes as well. And so I've been referring patients to my endocrinology colleagues who've been using semaglutide. Now, at the moment, it's technically off-label. It's not yet got its indication for this. But because a group of studies have now all been very consistent in showing this benefit, they've been prescribing these medications for our patients, and we've seen really quite profound and sustained weight loss, which then leads to all the secondary benefits. So I've genuinely seen patients with improved blood pressure. And what's great about it is when they lose weight, people feel better in themselves. They exercise more. They don't feel as embarrassed walking around on the road or going to the gym and doing things like that. And so it basically leads to a positive cycle of weight loss, health improvement, and all of that is really, really helpful. And I'm sure you've had patients over the years who say to you as a cardiologist, well, doc, what can I do to lose weight? And, we give them the standard advice. And I really usually emphasize the 30 minutes of walking every day. I don't try not to advise people to do huge amounts of exercise, because I know that often patients won't be able to sustain that. So I say, look, really what I want you to do more than anything else is just to walk for 30 minutes per day. And if you can do that at a pace that's fast enough to make you feel breathless, to feel fatigue, that's usually enough to start triggering weight loss. But then if you can add in a medication like this, as well as doing those lifestyle measures, I think we're really going to be at the cusp of improving a lot of patients' overall health. Because, as you know, we're essentially living in an obese world now, where obesity isn't just an epidemic, it's endemic. And The percentages, when you look at them, are absolutely frightening. The US more so, but as I understand it, even now in the UK with BMIs of over 30, we're kind of hitting the 30% level. So really quite significant. Is this something that you guys are familiar with? Is this something that you're using, Ankur?
No. So again, an extremely important study which was published in the New England Journal of Medicine, and like you said, obesity is endemic. Is certainly a modifiable risk factor, and has been shown in observational studies to be a cardiovascular risk enhancer, if not a traditional cardiovascular disease risk factor, certainly a risk enhancer. And one may argue it's in my assessment of what I've read in observational data, it actually is a cardiovascular disease risk factor. And so, we do have, if not vast majority, certainly a high percentage of these patients who are, either overweight or obese. And, once they have an event, I think they are intersecting with the healthcare system, definitely with the cardiologist. And I think it's an important opportunity for us, not only as cardiologists, but, like you mentioned, as general physicians, to implore them to reduce weight and adopt lifestyle intervention and lifestyle modification. And I think I probably misspoke. I think I said semaglutide. So that's
I call it semaglutide as well. It is technically semaglutide. Yeah.
Yeah. So semaglutide, and cost could be a deterrent, but I think in terms of convenience, it's a once a week subcutaneous injection. It's 2.4 milligram dose, and in the trial, the way the results were published and resulted, there was a significant weight reduction in these patients. So I think lifestyle intervention plus this medication in a significant percentage of patients that we see in the clinics is an important lifestyle intervention. I think from at least for patients, but also from a cardiovascular disease management risk factor reduction standpoint. So I agree with you. I think it's important to, at least be aware of this option so that you can refer your patients to, your endocrinology colleagues or to the general physician with this option of, hey, my cardiologist was saying that there's this drug out there. It's called semaglutide. I'm interested in its prescription. What do you recommend? I think that kind of conversation with someone who is prescribing this more than you and I are, I think is an important armamentarium in our patient's arsenal. So thank you for discussing this with the Parallax audience.
Yeah, I think it is useful, and I think we need to think a little bit beyond where we traditionally think. We spent much of our first podcast talking about antiplatelets, which obviously as cardiologists we're very much obsessed with, and we're obsessed with anticoagulants, and then relatively niche things like fractional flow reserve and things which are interesting to interventionists or some interventionists. But these things like semaglutide is genuinely a change that could alter, because you can imagine as the various different companies start to compete in this space. And remember, GLP-1 agonists have had proven cardiovascular benefit as well in the diabetic cohort. So this is a medication that has perhaps not as strong as the SGLT2s, but it does have a benefit of its own. So there is true merit in us pushing the diabetologists and the endocrinologists to institute these medications where they feel they can safely do so.
Absolutely. So moving on, I think let's start talking about a couple of the surgical trials from our surgical colleagues, that were presented last year, and I think are important, both for the cardiovascular community as well as our patients. Do you want to talk about them?
Yeah, I think, well, let's talk about AVATAR, because AVATAR was an important study that came out at AHA, and AHA was quite notable in the fact that it had a number of surgical studies, and it's striking because it is difficult for our surgeons to perform studies. It's hard to randomize patients at the time of having a major surgical intervention. It's hard for surgeons to want to recruit. It's hard for patients at the time of going under the knife to choose to be randomized for something that could is a very frightening and emotive subject. And so the AVATAR study was interesting because it looked at patients that I'm sure you'd be interested in. So this is those patients with severe aortic stenosis, but looked at patients who were asymptomatic. The management of aortic stenosis has always required the patients to be symptomatic before we intervene on them. And the reason that's been set is because surgical intervention, as well as TAVR, has a degree of risk associated with the intervention in itself. And if you've got an asymptomatic patient, then the feeling is that actually the risk of the surgery outweighs the relative risk to the patient. Of course, once a patient has breathlessness or syncope or chest pain, then we know from the classical Braunwald curves that were generated many years ago, ostensibly from recall, actually. So there is limited data value to those curves, but they looked to see the outcomes, and we know the outcomes diminish quite quickly in patients with symptoms. But what in AVATAR, what they wanted to do is a study performed in Serbia. They wanted to look at those patients who had got asymptomatic aortic stenosis and to randomize patients to having an early surgical intervention versus standard of care conservative approach, waiting for the patient becoming symptomatic. And it was a study that was designed to follow patients until they'd had an event. And the total number of patients recruited is relatively small compared to the kind of studies that we've got used to looking at in the cardiology space, like the type of studies we've just talked about with drugs. But of course, that's because the number of events needed to drive the outcomes was felt to be relatively small. And so they only needed to recruit around 157 patients in total in this randomized study. And what they wanted to look at was all-cause death, acute myocardial infarction, stroke, or unplanned hospitalization for heart failure. And they also looked at a number of other secondary outcomes as well, including 30-day mortality, which of course is only really going to happen if you've had a surgical intervention versus compared to being conservatively managed, major bleeding, which again is more likely in those patients being surgically managed, thromboembolic complications, and then repeated events as well. And what they showed was quite striking. What they showed was a significant reduction in the composite outcome, primary outcome, in those patients that had early intervention compared to being conservatively managed. And they saw a hazard ratio of 0.46 and the p-value was 0.02, so highly significant. And that is similar to data that's now was shown a couple of years ago, I think a year and a half ago, from South Korea, which also showed that surgical intervention at an early stage in asymptomatic aortic stenosis was also of benefit. So now you've got two randomized control studies that appear to show that these asymptomatic patients could be considered for early intervention. There are limits to it. I mean, these studies are small, and a number of the deaths that occurred in the control arm were perhaps for non-cardiovascular reasons. So, in fact, a couple of the patients actually died from COVID because, of course, at the time that this study was being done, intersected with the COVID outbreak across Europe. And so there is some limitations in how we interpret it. But it is useful data because we all have patients on our books that we see regularly who've got asymptomatic aortic stenosis, and we kind of push them, don't we? We always ask the patient the symptoms and we ask them the questions, and I think they begin to learn the questions that we're going to ask them, and I imagine that after a while they probably just relent and say, oh yes, I'm having these, I'm having fatigue, I'm having breathlessness. And it is quite hard in patients with aortic stenosis. They tend to be typically in their 70s. Patients are slowing down at that time. We keep telling them that they've got this severe condition, and so patients then slow down also. And then it's hard to know whether they really are having exertional chest pain or exertional breathlessness. And so it is a tricky group of patients to follow because you're never quite sure whether you're doing the right thing. But with these two studies now, I think there is data to suggest that you can push for early surgery. I suppose the key question that's going to come from this is, do these findings extend to TAVR, or TAVI as we would call it here in the UK, or TAVR as you would in the US? Hard to say. I would say it's certainly something that we shouldn't automatically assume is the case because, of course, patients going for TAVI tend to be a much sicker cohort of patients. And, of course, the technology is different and the type of intervention is different. So I would say that it's intriguing, but we definitely don't have enough data to say that with certainty. And my understanding is that you're a structural interventionalist as well, Ankur. So is this something that you guys do on a routine basis?
Yes, so I think patients with aortic stenosis who are asymptomatic and certainly moderate to severe or severe are a conundrum, are a clinical conundrum, and we do our best as physicians and clinicians to elicit symptoms and dive deeper into the history. It's interesting because our bodies are so well engineered that they modulate how much they want to exert, even if there's a little shift, and you may, as a patient, may not realize how you've been slowly dropping your activity levels, but your family members or folks who are near and dear to you and live with you may then after about a year say, what, I've seen a gradual decline in your activity levels. Now, patients may not be able to elicit that symptom themselves, but if it's not uncommon that if someone's accompanying their father or their husband, they'll be like, what, there actually has been a gradual decline over the past 1 year. Maybe a year ago you used to walk more than a mile, now you can barely make it a couple blocks and you want to take some rest. So I think I agree with you. I think we do in patients where we see objective findings and we cannot correlate them with symptoms, we tend to elicit symptoms. We do our best in eliciting those symptoms. But it's tricky because, I know that there are data available where if you compare age and sex match controls in patients who had versus did not have an aortic valve replacement, so everything else is matched. The only difference is these set of patients had their aortic valves replaced. It actually, their overall survival curve drops for some reason. Granted, our surgeons are excellent, and aortic valve replacement is one of the most commonly performed surgeries, on the planet, and the mortality is less than 1%. Unless that 1% happens to be you, then obviously it's different. But that aside, I think if you compare patients, like I just said, there is a difference in overall survival curve. So I do think it's an important decision for patients. It's not something that we can just, say, look, now we have these data and, patients do well. If they aren't really symptomatic, then what are you really improving?
Yeah,
right?
Yeah. So you're absolutely right. It is a very tricky area. And of course, I know there'll be many cardiologists out there, particularly if they subscribe to a much more conservative way of thinking. They would say, look, if the patient doesn't have any symptoms, how are you truly helping them? But I agree with you. There is good data to suggest that even in patients with asymptomatic aortic stenosis, there is a reduction in their mortality. There are mortality levels. There's morbidity as well. And of course, if you get an intercurrent infection, we have all seen patients like this, you get a pneumonia or you become systemically unwell with sepsis, say from a urinary tract infection. It's all very common in patients in their 70s. Then the aortic stenosis can contribute to a significant deterioration in those patients. And so now with these data, I think we can have a little bit of a better conversation. I think it's always been quite perverse before. We tell the patient, you've got this severe condition, but we're not going to do anything until you develop some really bad symptoms. And patients kind of look at us a little bit aghast. And we say, well, no, that's just how it is. But now with these, I think in select patients who want to go ahead and put themselves forward, I think you've got a little bit more support. Obviously, you have to have your surgeons on board, and I think surgeons naturally want to operate, and so I think that they will welcome these data, and certainly our surgeons have been very keen to take them on board and integrate them into our pathways.
Yes, absolutely. And I think to the point where we could extrapolate these findings to TAVR, I think that is an evolving area. I think there are ongoing randomized clinical trials in patients with, asymptomatic aortic stenosis, severe. I'm not sure if, we are onto our moderate aortic stenosis patients yet. I do know that, patients who have moderate aortic stenosis per hemodynamic criteria based on echocardiography and have a depressed ejection fraction, again, TAVR unload is going to, shed more information on these patients. These could be low flow, low gradient, severe aortic stenosis patients. So, these are, obviously exciting times, both for us as practitioners, but also our patients, because, these fields which, have been, stagnant for so long now with the advent of technology in both the surgical space as well as the transcatheter space, we are seeing an evolution in the treatment paradigms and management strategies for these patients.
For sure, absolutely. I mean, the speed of advancement and the way that the technology has improved in just short periods of time is really quite astounding. And I think we're very fortunate to be practicing cardiology and medicine at this time, because it really is offering patients really quite profound and useful treatments for them. And so I think it's great to be practicing at this time.
Absolutely. So moving on, left atrial appendage occlusion, is that the final study we're going to discuss for the show?
Yeah, I think so. I think this is an important study, which I don't know what your surgeons have been doing for some time. Certainly ours have routinely taken off the left atrial appendage at the time of surgery. So the concept is, if you're having cardiac surgery, say you're having your mitral valve changed or you're having aortic surgery, then the surgeon may in many places remove the left atrial appendage, which is this, think of it like the appendix of the left atrium, this little recess, this little groove that is often the site of clot and thrombus, which can then embolize. And this is very frequent, that in patients with atrial fibrillation, that they developed thrombus in this location, and that can be a cause of major stroke. But there hasn't been hardcore evidence. Much of it's been from observational studies and cohort studies, which we know have a lot of weakness and a lot of confounding. And it's really fantastic that this investigator-led study, performed predominantly from Canada, randomized patients who had atrial fibrillation, who were undergoing some form of cardiac surgery, so a mix of bypass, mitral valve intervention, or aortic valve surgery. In fact, I think the majority of the patients were having some form of aortic intervention. Just as you say, aortic valve surgery is one of the most common operations performed. And they randomized them to have a removal of their left atrial appendage. And they took around 4,700 patients, and they randomized them. And what they basically showed was a significant reduction of around 33% relative reduction in stroke over 3.5 years, with around 4.8% of stroke rate in the patients who had the removal of the left atrial appendage, and around 7% in the arm that were conservatively managed and did not have the left atrial appendage removed. And so this is powerful stuff. This tells us that we can essentially halve the rate of stroke in patients with a relatively simple procedure that can be done routinely at the time of another operation. And all these patients had paroxysmal AF or permanent AF, and they all had an indication for anticoagulation, with the average TRADS2 VATS score being of 4.2. So all the patients were anticoagulated. So this benefit was seen over and above the anticoagulation that was used routinely in these patients. And so that's really quite compelling as well. And perhaps there are some criticisms you can talk about, the fact that perhaps some of the operations being performed was a little bit niche. Some of the mitral valve interventions, mitral valve surgery can be complex and is performed by usually very specialists, subspecialists essentially in that particular cohort. And that can limit the generalizability. But what's great is that this was an international study. There was a good representation of the UK. In fact, colleagues from my hospital were contributing to this particular study. And so they all feel incredibly vindicated that what they've been doing in their routine clinical practice over many years has been proven in a randomized control study. Now, the difficulty is immediately, I think people, as we're interventional cardiologists, they'll look at it and say, look, this means that we should be putting in things like Watchman devices, or there is a percutaneous stitch technology that can be used to close off the atrial appendage. I don't think we should do that. I think those of us who may look at this study and say, yes, LAOS 3 basically tells us that we can go ahead and start putting in Watchman devices, because what the surgeons were doing was really quite different. They were usually closing off the appendage or cutting it off completely, or over sewing it, So one of the weaknesses of the study is that they didn't standardize the type of approach they used. And I suspect there probably isn't quite enough numbers for them to do subgroup analysis with great power. But I would say is that it certainly tells us that we should encourage our surgeons working in your hospitals and your facilities to be considering this in the patients they're operating on. Is this something that your guys do, Ankur? Is this something that's routine in your hospital?
So yes, I think in patients with atrial fibrillation, if they are being subject to open heart surgery for any other reason, most common surgery is coronary bypass grafting, as you know. And if it tends to be a common comorbidity, then, more often than not, surgeons would go in and ligate the appendage. So I think it was being commonly done and commonly performed. And I think LEOS 3 just provides evidence to the practice that was being done, really or commonly. So I agree with you.
So I suppose the difficult question then comes is a lot of patients after bypass surgery often have runs of atrial fibrillation. And partly that's because of the edema and the handling and the various milieu changes that can drive the atrial fibrillation. But often it's just because we see fast AF in patients. If you monitor patients for long enough, particularly many of our cardiac patients will have runs of atrial fibrillation. It leads us to a bit of a quandary. Should all these patients have prolonged monitoring? Should they be given an anticoagulant? And if the surgeon hasn't taken off the appendage, then should they have done so? So I think it kind of pushes us into removing the left atrial appendage in most routine operations when it can be performed. Whether it should be done in patients who've in sinus rhythm is less clear, but I can understand why some of our surgeons have begun to move in that direction because, if you look at the surgical literature, rates of AF straight after surgery are really quite high. And if they're taken off the appendage, I think they feel a little bit more relaxed about it.
Yeah, absolutely. No, I agree. I think, I think the surgeons now have, randomized clinical trial evidence to support what they were doing routinely in clinical practice. So I think, again, I think congratulations to the surgeons for, concluding a trial as comprehensive as LEOS 3. Like you alluded to at the beginning of the show, it's difficult to recruit patients in a surgical trial and randomize them. So, I think just congratulating both the surgeons and the patients likewise.
Absolutely. We should encourage our surgical colleagues to do more studies, and even studies that look like it's a solved or an answered issue, because the reality is relying entirely on cohorts and registry data is usually not enough for us to be definitive about answering questions like this. And it's really good. And when we get that answer, and sometimes we find that we've been doing the wrong thing, and that's also been true. There's been lots of medical reversals. And it's important for us to perform the randomized control study to check what we do is actually the right thing.
Absolutely. Well, Sukh, thank you, again for such an eloquent and detailed discussion. And it's always a pleasure to have you on board for the show. This is part 2 for the 2021 wrap up. And, do drop us your comments on Twitter and LinkedIn. I know both Sukh and I post when the episode comes out, and leave us feedback on Apple Podcasts, SoundCloud, and Spotify. And thank you, everyone, for listening. And Sukh, thanks again for being here with us on the show.
Thank you so much, Ankur. And I hope the audience enjoyed it. I look forward to all their comments.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.